Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Well, hello everyone. Welcome back to Research Works. It's so nice to have you here again. And if you're watching on the video, you'll see that I'm here by myself today. But this is not going to be, it doesn't mean it's going to be a small episode. It's going to be a huge one because we finally have Professor Alicia Spittle here. And I'm so excited to speak with you today. We've tried for a few months to line this up, but it's been a very busy schedule. But welcome, Alicia.
Thanks so much for having me.
Oh, it's so good. I've been looking forward to this so very much because we will be talking about a Cochrane review that was recently published, and it's titled Early Developmental Intervention Programs Provided Post-Hospital Discharge to Prevent Motor and Cognitive Impairment in Preterm Infants. So there's a lot to unpack there. But look, for all of our listeners, the really cool thing about this episode as well is knowing that this is going to be the last episode we're going to do before we head to the European Academy of Childhood Disability in Bruges, Belgium. So I think it's really cool to think about the fact that we're all going to be able to be gathered around together about all the things we can talk about in a conference. And it's work like this that I think really propels us forward. But before we get into it too much, I really am looking forward to just introducing with all the accolades of who Alicia Spittle is. So Alicia is a physiotherapist, clinical researcher, and a National Health Medical Research Council Career Development Fellow within the Melbourne School of Health Sciences. In addition to this, Alicia is the Associate Dean of Research in the Faculty of Medicine, Dentistry and Health Science at the University of Melbourne. And through these capacities, Alicia leads several grants that focus on early detection and early intervention for infants at high risk of neurodevelopmental impairments, including infants born preterm or with cerebral palsy. Not only has Alicia authored 160 publications, she was also recognised in 2020 as the top Australian researcher in paediatric medicine by the Australian paper for the highest number of citations from papers published in the last 5 years in the top 20 journals of her field. As a clinician, she works in the neonatal intensive care unit and follow-up clinic at the Royal Women's Hospital in Melbourne, Australia. It's pretty impressive, Alicia.
Yeah, thank you. It's I feel tired listening to it, but I'm lucky at the moment. I'm actually on sabbatical from my university job, so it's been nice to have some time to travel around the world, finding out about the latest research going on.
That's
but
incredible.
Also focusing a bit more on my research too.
Yeah, I love that. And we quickly touched on where you've been. And do you want to just tell the listeners where you've been over the last few months? Because it's pretty cool to think of where a research career can take you and where the collaborations are, right?
Yeah, absolutely. I've been really lucky to travel over the last couple of months. I've been in New Zealand at the Perinatal Society of Australia and New Zealand.
Wow.
And then I went over to LA and to Chicago to a conference over there, but also to do some general movements courses. And then I came back home again, and then I went to Toronto to the Pediatric Academic Society conference. And then in a month's time, I'm going to Malawi. So I've been really fortunate. But as you say, conferences are such an awesome opportunity to connect with people and hear about the latest research, but also to network and catch up with old friends and make new ones. So it's been fantastic.
Oh, that's absolutely
I unfortunately can't make it to EACD, but I'm very jealous, and I hope to catch up on the conference listening to your podcast.
Yes, that's right. That's the whole point of it. It's hard to get to everything, isn't it? Sometimes.
Absolutely.
There's a lot of things going on. Look, time is one of those commodities that's really precious. So we're so grateful that you've put aside some time to speak with us today. But of course, we always have an icebreaker. I may not have Ash here with me today, but I have an icebreaker for you. Now, this one I thought would be a really fun one. And I know that retirement is many years away still. But what would be the first thing that you would do on the first day of your retirement. What would that look like, Alicia?
Well, you are starting to make me feel old, but hopefully it is still 20 years away.
Yeah, that's right. Decades.
So I really enjoy running. So I'm hoping in 20 years' time, more or less, that I'm still running. So I hope on that first day of my retirement that I can go for a lovely run, hopefully a trail run. Beautiful. Down by the beach or in a forest somewhere.
Beautiful. That sounds amazing. And not have any limits on when you need to be able to be back for a meeting or something like that.
That's just exactly right.
Time. Yeah. Well,
yeah.
In a podcast first, we're going to ask Ed. He does complain that he doesn't get asked these questions sometimes. And, we don't have Ash here today, so I will indulge. Ed, what will be the first thing you do in the first day of your retirement?
So I'm very honoured to fill in for Ash and Marissa and Corinne. But a little known fact about producer Ed is that he used to work for Nintendo. And he used to play games for a living, video games for a living. And now that I'm all grown up.
Nice job.
Yeah, not bad, right?
It was a nice way to start my working life. However, as I've gotten older, I've stopped kind of playing video games, and I have this habit of purchasing video games with the intent of playing them, but never finding the time. So I will have a pile of shame, which is my entire collection of video games that I have not played.
Oh.
So 20, 30 years from now, I'll start from the beginning and play the original Super Mario Brothers and move on from there. So that might take my 20 or 30 years of retirement.
That sounds good.
Love it.
I like that. Gosh, mine feels really, really silly now. But in context, I want to say that I'm about to head to Europe for the conference, but I'm stopping through Amsterdam. And the first thing that people usually always say to me is, Dana, are you going to have, a special something? And I go, no, I'm not going to, because I don't know what impact it would have on me. And I don't know if it would sharpen me or make me a little bit less sharpened. So I don't know what impact it has. I know I need to be sharp. So I figure on the first day of my retirement, I'd like to see what that would be like, because it might embark on a new career of creativity, and maybe that's what I do for my retirement. So I probably need to work out whether I go there or I just stay away from it. But yeah, I would say every second person has asked me that so far. If you're headed to Amsterdam, are you going to? I'm like, no, I'm working. So yes, it's a little bit silly, but who knows? Maybe creativity might flare and I'll have a new career after that. We'll see what happens. Well, that jokes aside, I think we have a long way to go still when it comes to all the great discoveries that we really want to be able to have in our careers. And let's start with this Cochrane review. So just a brief rundown before we start asking Alicia some questions. So we know that infants born preterm and at increased risk of cognitive and motor impairments compared with infants born at term. For this reason, early developmental interventions for preterm infants target both the infant or the parent-infant relationship, or both. And whilst these interventions aim to improve developmental outcomes for these infants, the long-term benefits are unclear. And for this reason, this team of researchers wanted to update their last Cochrane review that was published and updated in 2012 and 2015. Now, Alicia, I think a really good place to start is actually just to talk about the value of a Cochrane review. And I guess why are Cochrane reviews so important and how do they differ from other kinds of reviews? Can you talk us through that process?
Yeah, so I actually started this journey almost 20 years ago when I first started doing my PhD. Thought it would be a good way to start is to do a systematic review. And I actually went and did a systematic review course, and they talked about the ultimate systematic review you can do is a Cochrane review. And I guess the reason it's seen as the ultimate is it's very much a standard methodology, and you have to have a standard protocol and a standard procedure for doing them. And back then too, Australia paid for open access to Cochrane too, and they still do actually, but there is more open access for other journals and things now. So it meant that if you were able to synthesise that evidence, it would be available to all those people in Australia, but also worldwide. A number of countries also are paid for open access too. So it was a fact that there was was considered the highest level of evidence because, well, not level of evidence, but the highest methodology in terms of stringency of the methodology, very strict protocols, but also that you could disseminate that work out there as well. And I think from coming in as a physio into the neonatal space as well, neonatology is renowned for being very strict with their research methodology and what's the evidence for this. And so showing with a Cochrane review in the neonatal library was really showing, well, actually there is evidence for this, or there isn't evidence for this. So I guess because it was 20 years ago, I went in a bit naive also as well, realising the commitment that it would take. And it's taken us, and it has been a great experience because it has been well read by people and well cited by people. So it does show you that it's needed. But with every update, the criteria that Cochrane set gets stricter and stricter. So there's something called the grade methodology now, which we can maybe talk about later in this podcast, but they've introduced that since we first began, and I guess different criteria that the Cochrane set too. But they do also have support for you as well. So because they have a standard set of protocols, there's a whole handbook that you can follow on how to do a Cochrane review too.
Wow. And I guess from there, it's very, very vigorous. I love how you describe that. And you have done, this is like another update. You've done that already. Why, in the time periods, when do you decide that you want to do it? Do you notice that there's a lot more research being published since then? You keep tabs on it, and that's when you go, okay, time to do another one. How do you make that decision?
Yeah, exactly. So several of those factors come into account. So one being, has there been a lot more research to actually update people on? And there has been in this case. And then a second is finding that time and the energy to go, okay, we're going to embark on this again, because for anyone who's done any type of systematic review, they'll know it's a lot of work. And you've also, it's not a solo job too. You've got to have friends who are going to help you review those papers together and get into it.
Yes.
So partly it was time, and then it actually took us, we started this process a long time ago, and then it went out to reviewers, and then by the time we got the comments back, they're like, you need to update your search again. I was just like, okay, take a big deep breath and off we go again. So, and I'm lucky that I do have a research position, so I have the time to do this. But in this latest version, which is updated by my colleague Jane Orton, is the first author on this version.
Yes.
She's a clinician and has little time for research, so it's sort of doing these things on top of your day job and other life commitments too. So it's finding that time as well. But there is a lot more research to update people on this time, and I have to say, even though the times the process did feel painful, since it's been published just 2 months ago, we've had a huge number of publications already citing it, and a lot of attention, including this podcast yourself. So it does make these things worthwhile as well.
Yeah, that's right. It's really spreading that information out to the people who need it. But I think for a lot of people who are not aware, sometimes a lot of this work is done in people's own time, and some clinicians who want to be clinicians and have research on the side, it's a huge commitment, and you don't just have endless time to do it. Like you said, that you probably want to review it in a period of time, so you don't have to redo it again. So there's a lot to consider there, and we're always so grateful for people who put time into this, because it just advances our field. Well, let's talk a bit about this population, and a population that you are well known for as a real expert in this area. And I was just saying before we started, I remember the first time I heard of you was when I was a young physio, didn't know much about research, attended my first conference 2008 in Brisbane. And I remember seeing you go up there to talk about what you're doing. I thought, wow, I did not realise this is what we could do as physios. This is incredible. And then since then, you've been still in this area, so just getting so much knowledge. So let's talk about this group of children, preterm infants. First of all, I guess, what's the definition of that when we talk about preterm infants? What constitutes that?
Yes, that's a really good question and a really important question. So preterm birth is defined as any birth less than 37 weeks. But when we are thinking about the babies that we're seeing, and when we're looking at the evidence, it's the babies who are born at the earliest gestations who are most at risk for longer-term developmental concerns. So those children who are born moderate to late preterm, so from, say, 34 weeks up to 36 weeks, they are still, well, that's late preterm, moderate preterm being 34 to 35 plus 6 days. They also do have increased risk of developmental impairments, but not as great as those who are born very preterm. So very preterm refers to less than 32 weeks, and then extremely preterm refers to infants born at less than 28 weeks. But I think it's also important that in recent years we've got a lot of babies now surviving at 22, 23 weeks gestation. So the ballpark's changing as to the infants that we're seeing compared to 20 years ago.
Yeah. And that's quite a range, isn't it? So we're talking about quite a number of weeks where things look quite different. Not an easy one to answer, but we can break it down. But, what are some of the impairments that we're really thinking about when it comes to preterm? What are we looking for there?
Yeah, so again, as you say, it's really important to keep the gestational age the baby's born at in mind. But if we think about when a baby's in utero, the last trimester, of gestation, is when a huge amount of brain development happens. And so the brain actually increases 4 to 5-fold in size. Wow. And so for a baby who's born, say, at 28 weeks, getting into that last trimester, their brain development is occurring in an altered sensory environment, and often having important medical procedures that they need to have to survive. But it can have an effect on that brain development, but also that the environment they're developing in, the separation from the parents, the different motor experiences that they're having, the different sensory experiences that they're having, can all have an impact on later development. Sometimes those are quite subtle, and some of these things might not be picked up until the child gets to school and might be having some concerns with more milder motor problems, or things like activities of daily living, handwriting, but also from a cognitive perspective, academic challenges might not become more apparent till later on. Sure. So they're the more subtle things, sure. But then we also, we know that children who are born preterm have an increased risk of cerebral palsy as well. And again, the earlier you're born, the greater the risk, but we also need to remember that those children who are born moderate to late preterm, whilst their risk isn't as high, they make up a greater proportion of the population as well.
Sure.
So we need to keep these things in mind too.
Yeah. And I think that's really important to talk about, because I think the worry that people might have is they think they link preterm, they think cerebral palsy, and there's a higher risk of it. Do we know what that risk actually is? Do we have a number on that?
Yeah. Yeah. So it varies throughout the world. And in Australia, we have very good antenatal care. So our risk of cerebral palsy is lower than in some other countries, which I think we should be very proud of. And we also have good interventions to help support the mothers, which then help support the baby's development. But for those children who are born extremely preterm, so less than 28 weeks, it's about between around 10% of children will have cerebral palsy.
Right, okay.
But then if we look at more considered milder motor problems, so things such as developmental coordination disorder, up to 50% of children who are born extremely preterm can go on to have developmental coordination disorder.
Wow, okay. That's really interesting. And so for those children, for developmental coordination disorder, I know we've spoken to a few people about that before, the age of diagnosis can be a lot later compared to something like cerebral palsy, isn't it? So is it a matter of for clinicians to be aware of that and to monitor and screen? Are there programs around like that?
Yes, that's a really good question, and that kind of forms the basis of what a lot of early intervention is focusing on. So a lot of programs are more thinking about being preventative, I guess, as opposed to waiting for a diagnosis and treating the infant. For these early intervention programs that we're talking about, often the infants don't have a diagnosis apart from being born preterm and potentially at risk of developing of these developmental impairments. So they're trying to get in early to prevent these concerns down the track. Yes. But one of the challenges with that is it tends to be a one-size-fits-all for everyone. So we can talk about the results of the Cochrane review throughout this podcast, but I think one of the challenges is that we can have sort of this preventative care approach, but then once particular concerns become apparent, then we need to target those interventions. So we actually find that the early intervention programs tend to be more effective for cognitive development than for motor. And part of the reason I think for motor is that potentially these sort of preventative care approaches aren't enough. They're good to get started.
Yes.
But as we know, like when I was talking about running, I really enjoy running, and I was fortunate to do a marathon last year, but if I don't keep training, I'm not going to be able to do another marathon. You know, we need to keep with our motor skills, we need to keep challenging those motor skills. And so I think as we know, in allied health, we often focus on having, you know, blocks of therapy or therapy throughout life and different ways that we can incorporate it into life. But it's not going to be that just having one particular intervention is going to be enough forever as well. I think if you've got an actual diagnosis.
Yeah, no, that's really good to lay that out. And a perfect segue to start talking about those interventions now. So I guess when we talk about interventions, what's the current recommendations when it comes to this? Like, what does it look like?
Yeah. So if we look at the results of the Cochrane review, so in the latest review, there's actually 19 new studies. So there's been 44 studies that we included in the review. So there's a lot of different studies. One of the challenges in this field is the interventions all look quite different. And some focus, as you mentioned earlier, some focused on the infant alone, some focused on the parent and the infant, and some focused on both. So we haven't teased out the sort of essential key ingredients, but the things that we have looked in some of the subgroup analysis are these interventions that if they do focus, interventions tend to be more effective for both cognitive and motor outcomes if they focus on the parent-infant relationship and the infant's development together, so not focusing on one or the other. And I think when I first started 20 years ago, and luckily things have changed and hopefully people are thinking, oh, why would you just focus on the infant development and not focus on the parent-infant relationship? But that used to be that people would come along to physio, the physio would do work with the baby and then the parents would come back later. Here you go.
That's right.
But what we know now is that it's really important that the parents are part of that intervention so that intervention can be continued throughout the day at home. So, you know, again, seems obvious, but really the data does show us that we need to be involving parents and really focusing on that parent-infant relationship. And that's particularly important for cognitive development because it's that interaction that's really important between the parent and the baby, reading, play. And, you know, I think that's one of the things that I was so amazed at when I first started working in this area. I thought we're going to be doing all these amazing physiotherapy sort of intervention techniques, but really a lot of what we do, as we know, is through play, but that play is so important. So just coming back to those basics of making sure the baby has time each day on the floor to play, in prone, you know, etc. So those things are really, really vital. And I guess the other big thing that we found is a key ingredient is that we looked at whether the intervention started when the baby was, so it had to have a post-discharge component, but it could commence when the babies were in hospital or once they had left hospital. And the other thing that we find is that the interventions that start, particularly for motor development when the babies are in hospital but continue post, are more effective than those that just start when the babies go home too. So I think really starting early is very important.
So a few things there that I'd like to really delve into, the value of play, the parent and infant relationships is, you're right, like over the last 20 years, things have changed a lot to such a point where it seems like a stark contrast now to say that back then we didn't really focus on that. But it comes down to that play element, and we talk about as clinicians a lot, you know, like, babies, children don't know that they're doing a physio session. Now they're going to OT and now they're going to speech. They don't, because play is the context of which they will learn all those new skills. So the value of things like nursery rhymes and reading books, all that kind of things, would you see that as like an act of dosage in a way, in terms of like, you know, something that's actually real? It's not just play, like, you know, in terms of therapeutic intervention?
Absolutely. Absolutely. And we're actually documenting that in a new study that we're doing, looking at early intervention, is what play family are doing through the day. But, you know, being specific and talking about play in sitting and play on their tummy, or what other positions for play that they use throughout the day, because it's also that variability that we want to see.
Yes.
Too. That so absolutely, I think dosage is really important. And things like nursery rhymes, that's another really good example, is talking about the importance of nursery rhymes and singing and interacting with babies. But we often find these days too, when babies come into clinic, parents might say for a 6-month-old, their favourite nursery rhyme, and then they'll pull out their phone and play that to you. And you think, what about, can we sing that nursery rhyme to them? So even just the modelling of play and the importance of that because that, as we know, it's not just there's so much that nursery rhyme, it's that interaction, the watching the person sing it to them, the baby responding back, getting that reciprocal interaction, potentially modelling of motor patterns that are happening with that. There's so much going on, but if we're playing a nursery rhyme off the phone, then whilst there might be some benefits, are you going to get all those benefits? So again, just reminding families the importance of different aspects of what seems so simple, like play or a nursery, specifically a nursery rhyme. It's loaded with all these fantastic things that we should be doing.
And when you think about dosage, I think any parent would probably tell you that at that age, your day is full doing all of these kinds of things. So I suppose if you were to be a scientist to watch it and to encounter every single event that happens of interaction, it's really quite a high dosage. It's not just a therapeutic session for 60 minutes and what you might get from that.
Exactly.
There's so much more to it. Really interestingly, to pull into that one, we spoke to Giovanni Di Liberto in Ireland, and he did some acoustic variation measurements in infants in neurotypical, and he found that at 7 months, if people are singing nursery rhymes to them at 7 months, there's cortical encoding that happens then. And he goes, the baby might not be responding to you necessarily, but they are actually interpreting all of this information. And it's the value of a nursery rhyme is beyond just a bit of a mere entertainment, I suppose.
Yeah, absolutely. And just to focus back onto the preterm infant too, because they are in the nursery for so long, their auditory environment is quite different to what the auditory environment a baby would have when they're in utero, because if the mum's in a meeting like we are now, they'd hear these conversations going on and a lot of talking happening, whereas if a baby is in the neonatal unit, they're not going to be hearing as much of these interactions that are going on.
Sure.
And then there's been some studies led by Bobby Pineda, who's an occupational therapist in the US, and they looked at brain development of babies who were nursed in single rooms. So it was sort of thought having a single room is better for development because the parent can bond better with their baby.
Sure.
But what they found is there wasn't as much interaction between, or as much conversation, and also the mums weren't then having conversations as much with other mums or dads or other family members, or the nursing staff weren't talking as much. And so that compared to having babies in open cots, and they actually found in terms of brain development that the babies who were nursed in the single bedrooms actually had poorer auditory development in the brain regions compared to those in the open areas. So it's just having a think about what are the consequences of everything that we do, and just thinking again about reading and talking is very simple, as you say, even without the infant interacting, but they're still getting that input and processing these things as well.
And that's what you mean by the sort of more generalised things that you might do to start off with.
Exactly.
Before there might be a diagnosis. Yeah, sure. So from a motor perspective, what does that look like when it comes to interventions? Like when I looked at your Cochrane review, I saw a lot of things that are listed that were part of that. It's quite wide-ranging really, isn't it?
It is, and that's one of the challenges with the Cochrane review is we're looking at so many different types of interventions and then trying to pull that data. But often people say to me, "You're a physio who works in a neonatal nursery. What on earth do you do?" And so if we think about a baby who's born preterm compared to a baby at term who if you think of a baby born at term, they've spent a lot of time in utero and they tend to be very flexed and curled up, whereas for a baby who is born early, when they're born, they don't have as much flexion and as much muscle control. So it can make it a lot more difficult for them to regulate their behaviour, or to even with interaction, it's harder for them to take in the world. So a lot of interventions often focus on positioning and handling of the baby, and then reading the baby's cues as well, so that the baby and the parent can interact at the appropriate time and get quality interaction. And then when they're not ready to interact, that they actually have that time for rest and for their brains to develop too. So a lot of interventions tend to focus particularly early on understanding behavioural cues and appropriate interactions.
Yes.
And also that positioning for play in a variety of positions as well. And then as the baby gets older, it's then focusing more on those play skills and the different aspects of motor development that we know are important for general development. But again, the interventions in the review, often some were very short, so the dosage really varied a lot. One intervention was only 4 sessions.
Wow.
And then on the other extreme, the Infant Health and Development Program, which is a large study that was done in the US several decades ago now, they had the intervention went for 3 years and then was very intensive. So there's a lot of variation there as well.
Yeah. Which, there's a lot of challenges there, aren't there, when it comes to what's actually going to work and what's the best. Okay, so that was a really good overview with regards to the intervention that was identified through this Cochrane review. But let's talk a little bit more about, I know it sounds like we're taking it a step back, but looking at what kind of study designs are, what did you actually want to include into this? Because it was very rigorous in terms of what you had to look at.
Yeah, so as I said, because we started so long ago, there wasn't as much literature, and so we had to have a protocol of what we were going to look for before we started. So we included any studies of babies born preterm, so any studies involving babies less than 36 weeks. And we included both randomised controlled trials and also quasi-randomised controlled trials. So again, high level of evidence, but we included those quasi ones that might be missing some aspects that are needed for to be considered randomised. So again, many of your audience will know exactly what a randomised control trial is, but for those who don't, it's making sure that the families, when they consent to the study, don't know which group that they're going to be in, and also the researchers don't know which group they're going to be in. And whilst it sounds like you can easily do that, there's little bits and pieces like making sure that the randomisation technique isn't known, so that the research nurse knows, the next patient's going to be
That's right.
in the intervention group. We'll wait to recruit that one because we want that one. So things like that are really, really important. Sometimes it's hard to randomise, because if you've got a certain nursery, the mum or the parents next door might speak to the next parents and tell them about the intervention. So some people might do what they call blocks of intervention. So everyone gets the intervention for a certain period of time, and then the next period that they don't. So there's different aspects to make sure that they're really that high level of evidence.
At the end of the day, it's all about managing bias, isn't it? When I try to describe it to people, we're just trying to make sure that we're not leaning one way or the other. We want the science, the numbers, the results to speak for themselves so we can trust it. So when it came to, like you mentioned before, what were your numbers again? You said there were 44 studies that were included, 19 of which were new, which is, seeing that you did the last one, 2015, that's quite a lot of new studies done in that time. What happened there? Why is there more focus there?
Well, I think, as you say, over the 2 decades, like I've seen a huge increase in the people interested in this area, which I think is great. And I feel proud in some ways that I feel like I've increased the awareness of the importance of these interventions. But also I think previously there's been some faults with the interventions as well, or they haven't, even though there's been evidence there, they haven't been able to be implemented into practice. So I think people are then looking more now at the feasibility of intervention. So even though the review that we did in 2015, that had 25 studies, and it had around 5,000 participants included in all those different studies once you add them up.
Wow.
In the additional 19 since then, there's only 600 participants. So what people have actually been focusing more on in more recent times is more feasibility studies and pilot studies to make sure that the interventions are actually going to be feasible before they embark on a large RCT. So I think that's been the difference. There's been a lot more smaller trials.
Sure.
But interestingly, there's also another 17 studies that we identified that are underway at the moment but don't have results for too.
Wow.
So it really is quite a booming area. And
when's the next
Cochrane review? I know. Well, that's get one out. You think, oh, when are we going to have to do this again? But we are going to. We are going to have to update it probably in the next 5 years. But yeah, it's overwhelming sometimes. But it is an increasing area that I think people can see the need for. But I think there's more trials going on around the world now as well. So often trials. Yeah, exactly. So there's more trials occurring in low and middle income countries as well, which is great.
So the process of doing a systematic review, so those who've embarked on it will know that how you extract the information and you put it into tables and you map everything out. Look, I won't get you to go through it in painstakingly detail, but I think it's worth going through that process in terms of the outcome measures, because there are quite a few outcome measures when it came to motor and cognitive. What were kind of those measures? What do they look like? It's hard for a lot of people to imagine what a cognitive measure would be in this group of children. But then how did you extract that? What was the process of doing all of that? And let's start there.
Yeah, so really good question. And I guess if we focus on infancy, so again, because these studies, there were so many of them and they varied, but so what we then tried to do was group outcomes into those ones that were done from 0 to 3 years, those that were done at preschool age, those that were done at school age. So if we just focus on the preschool age, with cognitive outcomes, some people might be aware of the Baileys and the Griffith are two common measures of cognitive outcomes. And they're quite comprehensive assessments that look at different aspects of cognitive development, and sometimes language is included within that. Sometimes it's not, depending on the different versions of the Baileys. Yeah. And they look at play skills and different, even things like puzzles and things like that to get an awareness of cognitive development. But it's called a development quotient as opposed to intelligent quotient at that age, because you're looking more at the developmental levels. Yeah. And then motor, it tended to be the same measure again. So again, mostly the Baileys and the Griffith. And some people, which I agree with too, would argue that they're not the best motor. They've got their role, but they might not necessarily detect some of the more subtle challenges that children have that we're often targeting with intervention. And then other people did use other motor outcomes such as the Alberta Infant Motor Scale or the Peabody, but because they're quite different, we couldn't pull them in the meta-analysis. Yes. So I think that's important to be mindful of. And then I think the other really important thing, and so what we basically had to do with all those studies is draw out what the difference between the groups were and put them into a database to compare those values. And then there's a program that spits out the outcomes for you, which is fantastic. But I also think it's important to highlight for families, are these the best outcome measures? And this is one of the challenges that we have in measuring the effects of our intervention, because to a family, do they care that their child scored 3 points higher or 5 points higher on the Bailey scales of motor development? So true. Or do they care that their child is able to participate in getting dressed in the morning, or are they able to so just, I think it's important that we think about the different kinds of outcomes that are important to parents as well, and they're often not well measured in these studies. Yeah,
I mean, raises such an interesting point when you brought that up. There'll be, when you think about preterm, sometimes it's quite traumatic for some families, and so the fact that they all survived, they're really grateful, and they want to move through that process. And it's a different process, isn't it, to the one that's completely unexpected. This has happened. What do you mean? And there is that grief and that process. So again, the expectations are quite different when you look at that.
Yeah, absolutely. Yeah, and that's what got a PhD student who's working with us at the moment, Fran Finlayson, and she's been doing some interviews with families to find out about that experience. And that is important. A common theme that people talk about. They're grateful that their child is alive, which of course they would be, and they're really excited to have them as part of the family. But then as time goes on, then these other more milder challenges come up, and the importance of those two. And we know with a lot of more, what are considered mild challenges, that sometimes they can be a bit invisible and people don't necessarily see them or understand them, and that can be quite complex for families and the child as well.
Yeah, that's absolutely true. I mean, when you have conversations with families, you have, like, let's talk about cerebral palsy for a second. You'll have families of children with GMS level 4 and 5, and they will often go, oh, for your child is GMS level 1 or 2, look, it's great, they're walking, they're doing all these things. And, but then a parent of a child with GMS level 1 and 2, they don't realise they've got ADHD and maybe some comorbidities that's associated with that. So it's quite different, but it might be quite invisible. Some people don't quite know they've got cerebral palsy and how that impacts them. So the impact for each family is so different, and always worth keeping in mind above these outcome measures. But back to this then, I think before we go into all the results, which I can't wait to get into, but it's worth probably just going into the grade approach, because you did apply the grade to this, because it's so important, isn't it?
It is really important. It's quite a complex way of looking at things, but it does help us in terms of the certainty of evidence, because not all research is the same. There's some really high quality trials that are done, and then there's those that are of less high quality. And what grade does is it takes into account this, what we call the certainty of the evidence. So if we're saying there is an effect, how certain are we? Are we highly certain, or is actually, the research wasn't very good, so we really can't be certain of those results? So for each particular outcome that we looked at, so as I said, we looked at cognitive outcome in infancy, at preschool age and at school age. We then went through and looked at all the evidence related to that and how certain are we of that evidence. And it takes into account that risk of bias that we talked about earlier, but also the size of the treatment effect. So with the motor outcomes in infancy, the effect size is quite small, and we can talk about that in a moment. And so it takes into account those things, and then we can score things as having high certainty of evidence, moderate or low. But one of the challenges with grade is it does downgrade things if you have this risk of bias. So one of the challenges that we had is that most of the interventions, the participants or the families aren't blinded to intervention because it's very hard to do that. But then we had to downgrade the evidence for that because it's part of the grade. So there's things like that become challenging in the work that we do too, that we might disagree with, but they're like, no, this is how grade rates things, so you have to downgrade the evidence. It's like,
it's very frustrating, isn't it? I mean, you see why that happens when it comes to drugs. You don't, you can do double blinded, but in our field, not very possible to do. So it's quite a rigorous process. So once you've done all of that, you do finally come to the all-important results. Finally, we get to talk about that. So what were some of your main findings? Was there anything that surprised you? Maybe we'll start with that. Was there anything that surprised you about the results, or do they just really confirm where you were thinking?
So since we've done the update, the results are very similar to what we've found last time. And I think, I don't know if it's surprising or whether because there has been so many more studies in this field, but there's actually very high grade of evidence and very strong evidence to say that early intervention for preterm infants improves cognitive outcomes in infancy, but also even when you start early, there's still those changes at preschool age.
That's amazing. That's huge.
It's not part of standard care when there is actually such strong evidence and it's consistent, and we continue to see that updated. Unfortunately for motor, so when we first started, there was no effect on motor outcomes, but as the research has increased, we actually are seeing an effect on motor outcomes, which is great. But the effect size is still quite small. So even though it's what we call statistically significant, the actual clinical significance of that is quite small. So it's good that we're seeing that evidence, but we do need we need stronger evidence for the right types of motor interventions. And as I said, I think that's partly because this preventative approach is a good way to get started, but we probably need more down the track as well. And I think the other thing, I don't know if it's a surprise or just a thing to note, is we have looked at the longer term outcome, like does starting early have an effect long term up to school age, and the effects tend to wash out by school age. And I think I'm not sort of surprised by that because, as I said, I think we need to keep intervening as well. And so I think when people think, oh, well, it's not effective because it doesn't have that long term effect, well, I think, well, that's maybe we shouldn't be expecting that as well. In the same way, if you go to school, it's not like you just go to your first level of school and then that's it. You need to keep going to school to improve on those outcomes as well.
I think all those results are actually really incredible. The fact that, so cognition-wise, I'm not entirely sure we consciously think about the impact our interventions can have cognitively sometimes. I don't know if that's the right way to say it, but because there's always been such a focus on motor, particularly maybe because I'm a physio, we always have very physical-based goals. You know, they're the motor milestones you don't meet first, and they're the ones that you focus on. Yet if you include all those sort of infant and parent relationship-based interventions, that speaks volumes when it comes to the value of that when it comes to cognition, and that does last. But then the point that you made about increasing, like you didn't find the impact or the effect for motor in the previous one, but you did here, and there was a small effect. It seems like we might be heading in the right direction. Were there any particular interventions that you saw that were different or compared to the previous one?
Yeah. So there are more interventions that I think so previously a lot of the interventions were the physio ones, but they focus more on the infant.
Yeah.
The more recent interventions involving physios are starting a lot earlier and actually getting the infant more actively involved. So in the past, some of the interventions were a bit more passive, whereas I think getting that infant actively involved is making a difference. And I think the other thing, as you say, we're getting more of an understanding now of the importance of motor and its effect on cognition and language.
Yes.
So we know if we can improve motor outcome, then a baby can explore the environment, which then helps them with their cognition and their language development. Being able to have those motor skills and that behaviour regulation skills makes it much easier to interact with other people and engage and have those social interactions. So I think there's been an increased understanding of the importance of motor development in overall development as well.
I feel like that's becoming very consistent now when it comes to active involvement. I always, when I talk to people, I'm like, I know I sound like a broken record when I say it, but it's true. Like active self-initiated movement is how babies do develop. They explore. There's the on-time ability framework when we spoke with Andrina Sabay and Heather Feldman in the US was all about getting babies up and moving when they should be, doesn't matter what diagnosis, but getting them to explore because cognitive socials nestled within mobility experiences. What would your advice be, I suppose, from clinicians providing these interventions? You know, what could this look like for everyone if we want to start really using this evidence moving forward?
Well, we can actually start these interventions even earlier. So not waiting for 6 months, 12 months. Yeah. Babies in the neonatal nursery, when they're ready, so rather than reducing stimulation to nothing, when you've got the right time, that you can actually start to challenge them with their motor development and their behavioural cues, if in a supported manner. But we can actually start that active learning really early because they're learning from the day that they're born. So rather than thinking, we've got to wait for them to initiate those movements, actually you can start supporting them very, very early in that active play. So I think really getting in early, and that's what I think the difference is in the more recent research is starting earlier. And when I was at this, one of the conferences I was at in Toronto at the Pediatric Academic Societies, one of my colleagues, Vincent Galeo, was talking about mouse models of preterm birth and looking at different types of environmental enrichment. And he showed that if you started early and continuously, you have a greater effect on outcomes than if you started late and only had a burst, or if you started late and you had sort of looked at 4 time periods. If you just didn't do anything, there would be some recovery, but you wouldn't get the same amount of recovery. So there's this consistency too between what we've found in our review and then what's happening in the preclinical space as well, which I think is really important. But starting early, but then continuously, I think is the key things to take away.
Yep. And that result about not seeing those effects necessarily last into school age.
Yeah.
What would you recommend there? So if things are sort of looking good, preschool sort of age, if they are born preterm, is the advice to maintain some contact with health professionals to monitor or provide strategies? Like, how can we get that sustained if they're not seeing the real impact until maybe, the school load increases? What can we do there?
Yeah, really good question. And we've been trying to push. We've recently published some National Health and Medical Research Council, so the NHMRC, endorsed guidelines for follow-up of preterm infants. And the important thing is, I think, as you say, is surveillance over time. So not saying up to 2 years tends to be what happens, but what we want to see is follow-up up until like that 5-year preschool school entry age, because things can look good at 2 and that can be reassuring to families, but it's also important to let families know that prior to going to school or in that first year of school, it's really good to do another assessment just to check how things are going, but also because it's not until some of those higher level skills are challenged that we can start to see some of these things become more of a challenge. So I think that surveillance is really important. So you don't necessarily have to keep doing intervention if everything's okay, but making sure that there's regular surveillance points. So then if an issue is identified, that particular issue can be addressed rather than having sort of a generalised approach that we've got to target any of these possibilities that you might have challenges in their area. No one has time for that. It's more about going, and there's, general principles that we know being active is really important, being social is really important, but do those things in the community. You don't need to go see a physio to do that. You're much better off doing an activity that you enjoy in the community. But then when they're getting to school age, often having an assessment at that time point, I think, is really useful, and particularly in terms of academic skills as well. Yeah.
Quick question on that one. When it comes to surveillance, is there any particular assessment you would recommend? Like, who would they see for surveillance? Would it be a paediatrician again? Would it be? What would that look like?
Yeah, so we're advocating for paediatrician and also psychologist, and then potentially physio OT as well, for something like the movement ABC is a good assessment tool to do, but that can also be done by the paediatrician or the psychologist, depending on where their skill sets lie as well. But having that complementary assessment of both allied health and medical at 5 years.
Yeah, that's really good advice. Okay, well, I feel like we've spoken about a lot of that in so much detail. But is there anything you think I've missed here, or anything that you feel like you really want to make sure people know about? It was a big review, so many pages.
Yes, I know. I think we've had a really good conversation, which is great. But I think people should feel confident that there is good evidence to say early intervention for preterm children does improve cognitive outcomes. And for motor, there is less evidence, but there is evidence to say that it supports motor outcomes, and they should be targeted to the child. If the child then goes on to get a diagnosis of CP or other diagnoses, then we need to target those particular diagnoses.
Yes.
But a preventative approach is a good start to life, and there's evidence to say that that's what we should be doing.
Yeah, no, that's wonderful. That's a beautiful summary. And I know we've kind of touched on it a little bit along the way. You've told us about some studies that are happening, and we'll expect another Cochrane review in 5 years' time. But is there any sort of research or work that you're doing at the moment that's sort of feeding into this, or has this pushed you into a particular direction again?
Yeah, so thanks for that. That's a very good question to ask. So one of the things that I am particularly interested in, because there has been so many studies done, but it's not being implemented into practice, is looking at interventions that are actually going to be feasible to implement. Beautiful. So we're doing a telehealth intervention at the moment. So it's a study called PRETERM, and it's a large randomised controlled trial of babies born at less than 32 weeks. And what we do is we start the intervention with the families in the hospital face-to-face to make that connection face-to-face with their babies, and we start the intervention very early. But then once they go home, we continue the intervention via telehealth. And the reason we're doing that is for that continuity of care, and that and then we have that preventative care approach, which reduces over time over that first year of life. But depending on what the needs of the baby and the family are, we can then link them into community, like local services. But they've got that continuity of care as well. And I think probably from a physio perspective in particular, we're focusing also on mental health. And I think a lot of physios struggle a lot with that. As you say, we often focus on the motor without thinking about the importance of the parent and the infant and how we play together. And having a baby that first year is really hard. And we need to be mindful as therapists what load we're putting onto families as well, and just being able to check in with families and asking how they are. So I think hopefully we'll start to see more of a focus as well of physios and OTs and other areas of allied health also thinking about that mental health. And we've got psychologists supporting us in doing that, and we do link families in to more appropriate services if they need those services.
That's wonderful.
But that we are thinking about the parental wellbeing as well. And parents want that more now, I think, than ever before, and are happy to communicate that too. Whereas back when I first started in this field, we did an intervention with psychology and physio, and it was a bit like the families were a bit resistant to having that input. But I think most people now realise you've got to look after yourself first before you can look after anyone else. So really focusing as well on parental wellbeing too.
Oh, that sounds so exciting. And I love that, because I would have to say we've been speaking to a lot of people on the podcast lately whose results are now being published, but they were all done during COVID. And so there was a lot of telehealth interventions, both from psychologists supporting parent interactions with their child and behaviour, as well as for early intervention. We spoke to Elena Metaego about the iHeart study, children who've had congenital heart disease and supporting them at home. They had to do that then, but then I think we've all gone, actually, this is quite good from a continuity of care perspective, and we're all more amenable to this now when it comes to doing things online. You know, we've got more tech that helps us. So that is very exciting, Alicia. Thank you for sharing that with us. Look, I think this is going to be something that will continue to evolve, and we will be in touch with you again. So I will just expect another email from me when I go, let's try to schedule another one, Alicia. It was absolutely fantastic. And to all of our listeners, I really encourage you to have a look at this Cochrane Review. There's beautiful family summaries, consumer summaries that you can read as standard with Cochrane Reviews too. So really encourage you to do that. I'll put a link for that on our website on researchworks.net. And of course, there's a form there that you can fill out as well to keep this as part of a record of your PD requirements. But I'm going to have to say, sorry, Ed, we're going to boot you from this one because we have actually gone a little bit over time, but we really wanted to keep talking. But you got to do the intro, so that's absolutely fine.
I did. Thank you.
There we go. Alicia, thank you so very much for your time today. I absolutely love that conversation. Thank you.
Oh, thank you so much. Really enjoyed it too.
Oh, that's fabulous. Well, stay on the line. I'll tee up another meeting with you. But to all of our listeners, thank you once again. And we'll talk to you all again next time at the conference. Bye.